moving on. So I'll just begin with this. What is the screen and what is this concept? When did this start? Screening, the word screening techniques are probably it started around 1960s, I would say. And a set of criteria were formed by these two guys, Dr. Wilson and Jagannath. So they proposed that if you want to screen for a disease, that means we are screening before the actual symptomatology is happening. So they put up a set of criteria. So any disease should fulfill those criteria so that we can use the screen. And remember, this was put way back in 1968, and these guidelines are still very much valid to say that whether a given disease qualifies for a screening test and whether a given test really can qualify for doing a screen. So it has to be an important health problem, and the treatment is accepted for patients with recognized disease. There should be facilities for diagnosis, and there should be a latent or an early symptomatic stage. So where we are able to pick it up, it should be suitable, tests should be available, it should be acceptable, the natural history should be known very well. And so these are the 10 I think can go through. So, and all these things are fulfilled by the one of the common disorders, that is hypothyroidism. So hypothyroidism, by looking at this criteria, meets the screening criteria. So hence it is very much indicated. Okay. Now, does our country need it? So it is very well known that the universal thyroid screening is the norm across the globe, but still we are still catching up. We are not at in the universal phase. Somehow logistics, I don't know why it is still not being implemented. It is being implemented in a hodgepodge manner. Private sector is doing in most of the centers, but government sector, some they are doing, some are still, many are not doing. So still it is very erratic. The coverage is very erratic. It is important across the globe, but it is all the more important in our country because if you see the incidence, this is from the Lancet database by Rajendra Prasad, a good friend of us. So he did a meta-analysis and published in Lancet Regional Health. So where they found that across several studies from our country, the incidence is almost 1 in 1,000, if you can see. In comparison to the global prevalence, which is almost 2 to 4 times more, our prevalence is almost very higher when compared to the global average. So we need it more than anybody else, but still we are not doing it. And we still have pockets of endemic areas in our country, and there, if you can see, the number is too large. And for those, if the mother is already suffering from some thyroid disorders, which has almost become universal nowadays, many mothers are having thyroid issues during pregnancy. And there also it is quite high, 50 per thousand. And in preterms, you will be surprised to know they are at much higher risk when compared to the term babies. We are still not able to do in healthy term neonates and preterms. I don't think anyone is, every preterm, I'm not sure whether they are receiving this thyroid screening or not. They are also much more in need of a screen when compared to a term baby. So this is just to give an overview as to why there is a need. So it is very clear there is a need, and the disease qualifies very much the criteria which have been laid as old as 1968, the Wilson and Jagannath criteria for a screening test. So we are sure that, so I don't think anyone has a doubt whether to screen or not. Now, what to screen or when to screen rather. So this is a peculiar scenario for thyroid because and the physiological changes that happen in the immediate postnatal life puts the baby at a different perspective. So we cannot screen as and when we want. So there are specific timelines where you should screen. This is because you all know the postnatal TSH surge. So I think every one of you know this. The moment the baby is born, there is a temperature drop. And it is said that that temperature drop is the trigger for the TSH. So there is a sudden surge in the TSH, very rapid surge. in the TSH immediately after the delivery. The TSH rises immediately within the first 12 hours. There's a surge and it peaks around 24 hours. And then after that, it gradually tends to fall down over a period of 72 hours. Because there is a TSH surge, T4 also surges with a slight delay, and then it takes much more gradually. It comes over a period of 3 to 5 days. So, because of this phenomenon, we should not be able to do the uh, screening at all time points. So, if we do it in the 24 to 48-hour window, there is a physiological rise of TSH. So this, if we use the routine cutoff, then you may end up creating unnecessary tension in the parents, as well as you will be overloading the system for screening the thyroid. Okay, so that is why we should avoid. So we have two windows now. Either we do before, just at birth, before the TSH rises, or you do it after 48 hours. Okay. So which one to follow? So you have both methods are equally good enough. In picking up, the pickup rates are almost similar, whether you use the cord sample or you use the whether you use the cord sample or use a postnatal sample. So, but the it's only the difference between the pros and cons are only with respect to logistics. So, if you are using say cord sample, there is a lot of blood. There is no dearth of blood for you. You can take as much sample as you want. You are not pricking the baby, so there is no pain involved. The only precaution you have to take is you don't prick the maternal vessels. So you have to take the proper cord and then don't prick at the placental side. Take it from the cord proper. So that is the advantage there. But the problem is if you look at in a large scale community wise, so you need a person who has to do it around the clock because deliveries do happen in the middle of the night. So you need a dedicated person who will be taking the sample, who will be labeling it properly, sending to the lab, writing a form. So all those things have to be done. So if that can be ensured around the clock, then cord sample is the best. Versus postnatal sample. Postnatal sample, as I said, you can't do it once you miss the cord window. So you have to do it after 48 hours. So after 48 hours, you can do it. The other advantage is you need not prick a wean. So because venipuncture involves a lot of skin. So don't imagine yourself doing the screen. Look at the community large-wise in a remote PHC. If the baby needs a TSH, so there the sister or the health staff should be competent enough to prick a neonate also. So that is why filter papers are considered the best because you can just do it with a heel prick. A simple heel prick will do to take the sample on a dried filter paper. The other advantage in postnatal sample is if you want to club it with other screens, like if you want to do a 17 OHP, if you want to do a G6PD screen, if you want to do the metabolic profile. So all these things can be done in a single filter paper. That is a major advantage for the filter paper based sample. Whereas in a cord sample, you cannot do a 17 OHP, you cannot do the amino acids TMS. So those things cannot be done if your screening is based on the cord. If the screen is based on cord, then you end up using only TSH. The other parameters cannot be done. So these are some of the postnet, but using a filter paper method is little skill intensive, rather technically intensive thing because you need a special devices to extract the serum from the dried blood spot. So it is not a simple centrifuge there. There are special techniques to extract the serum from that. So that needs a different level of technical expertise and the lab services. So that needs to be ensured. So if that is available, postnatal sample can also be done. The other disadvantage of postnatal sample is uh, you need what do you call the baby should be discharged only after 48 hours in a very high volume setups in like in a government sector in normal delivery babies may not be waiting till 48 hours, they may be discharged early also. Okay, So it's not that you should not do, if suppose a baby is getting discharged, say at 36 hours, or so you don't deny that baby for a TSH screen. You can do it, but you need to apply a different cutoff when you are analyzing that sample. So only that needs to keep in mind. So don't deny the baby. Suppose the baby is getting discharged early within 24 hours or within 48 hours. Please do send a sample by the heel prick filter paper method. Uh, but the cutoffs are slightly different, which I'll come across later. So these are some of the pros and cons of each method. But if you look at the recall rates, so that means positive values, whether it is cord or postnatal sample, filter paper versus venous sample, that the rates are very much similar. There is not much difference. So don't worry. It's only the logistics that decide either a cord or a postnatal sample. Okay. So it all boils down to your unit, to your own hospital, whichever is feasible, try to do it, but do it. That is more important. Now, the next thing is, okay, you are taken the sample and which test to order. So we have now TSH, you have T4, you have both. So ideally both. If you do TSH and T4 together, that will be the best strategy, but it involves cost. So as I said, when you are looking at a nationwide screening, it involves a lot of cost to do both. So nowhere, most of the countries across the globe, they follow only a single parameter. They test only the single parameter, that is TSH. You can use primary T4, that is, you can use T4 as a primary screen, followed by when you recall the baby, then you can do it as a TSH. So that is also can be done, or you do it primary TSH. But most of the evidence says that doing a primary TSH is the best strategy, because false positives and false negatives are very less when compared to doing a primary T4 as a positive thing. For example, if you do primary T4, so you may have a false positive test. That means, so T4 may be, unnecessarily be low. T4 may be low initially because of many reasons, so but may not be an actual congenital hypothyroidism. Or you may have a very high T4, so that also you may not be picking it up. So that is why both false positives and false negatives are higher in case of one example. Classical example is TBG deficiency, even though it is rare. So when you have because you are measuring total T4, if you have a thyroid binding globulin deficiency, the T4 will be low, spuriously low, but the baby is not actually having a hypothyroidism. So that is one problem with primary T4 workup. Okay. So that is why the consensus is to do a primary TSH. But if you do a primary TSH, you still can miss a central hypothyroidism. You may miss a delayed rise in TSH, which happens in case of preterms. So there could be maybe having a low T4, but the TSH is the response of the TSH may be delayed in certain situations, especially like preterm or in a sick baby, there could be a delay. So in such cases, you may still miss, but these are very less. So that is why doing a primary TSH is considered the best strategy for screening. Okay. So that is the consensus here. So both, it can be done, but it is costly on a nationwide basis, not feasible. Whereas primary TSH is the best for a nationwide screen. Primary T4 is not done. Very few countries in the world, like Netherlands, they follow this primary T4 as the screen. Okay, followed by a backup TSH. Now, when do you recall? So you have done a sample, cord or postnatal. So you have sent a TSH. So now the results are out. Now, when do babies are discharged? Now, when do we call them back? So, so when you are calling them back, so if you are using a primary TSH, I said that is the best strategy. So if the TSH is more than 20, you have to call them, because that is abnormal. So in the first, because you are doing in the first week of life, any TSH which is more than 20, so you have to recall them. Okay. Suppose you get a value of say 35 or something in the first screen itself. So 20 and 40, then so you have to call them. So anything more than 20, you are calling the baby back for further management. Okay. Suppose if the value is between 20 and 40, then you can call them anytime in between within first 2 weeks of life. So there is not urgency. No need to call them immediately. It is better if you can call them, but at least before the second week of life. So you have to call them and then do a repeat testing. So remember, if it is between 20 and 40, you call them in the within second week of life. Suppose if it is more than 40, then you have to recall them within 3 days. Within 72 hours, you have to recall them for a retest. Okay, so this you have to keep in mind. So suppose if it is more than 80, then you have to call them immediately. You take a sample and then you start the treatment. You don't even wait for the results of your confirmatory sample. So anything between 20 and 80, you can retest, wait for the confirmatory sample. If the confirmatory sample confirms the hypothyroidism, then you can start the treatment. But if the screen itself is showing a TSH of more than 80, then you call them immediately as early as possible. You take a confirmatory sample and you don't even wait for the results, but you start the baby on levothyroxine. So this you have to keep in. So this is how you have to go about on analyzing the results. Okay. So when you are retesting in any of these scenarios, what samples you will send? Don't send TSH alone. Please send TSH and T4 or free T4. So either with TSH and T4 or it has to be free T4. And it has to be better a venous sample. Try to avoid sending a filter paper again. It is better to do a venous sample. Confirmatory is always venous sample, no heel pricks, and you have to send both TSH and T4 or free T4, whichever is feasible. Free T4 is costlier. So if the patient is affordable, you can send a free T4 because TBG deficiency gets ruled out if you do a free T4. The difference here is that only for that. Total T4 versus free T4 is, if free T4 is T4 is low and free T4 is normal, so that means it is TBG deficiency, thyroid binding globulin deficiency. That is the only scenario. Now, so you have confirmed that it is a case of, you have the sent a repeat sample, confirmatory sample has been sent. Now, when to start treatment? So before starting treatment, you need to remember these numbers: 20 and 10 for TSH, 10 and 8 for T4, 1.17 and 1.10 nanogram per DL for free T4. Please remember these three values. For TSH 20 and 10, 10 and 8 for T4, 1.17 and 1.1 for free T4. Because I'll be repeating these numbers. Basing on these numbers, you will decide when to start the treatment. Now, when do we call a normal? So you have sent a confirmatory sample. When do we call normal? So any value which is less than 20 milli international units per liter. So these are all serum units. Remember, the lab has to report in serum units only. Okay. So less than 20 milli international units per liter in the first 2 weeks of life. So, or if the baby is already more than 2 weeks, then the TSH has to be less than 10. So for a neonate who is less than 2 weeks, TSH has to be less than 20. For a neonate who is more than 2 weeks, the TSH has to be less than 10. So if these numbers are fulfilled, then it is a normal TSH. When do we call a normal T4? So T4 has to be more than 10 microgram per deciliter. FT4, it has to be more than 1.17 nanogram per deciliter. So if you have both within these ranges, TSH is less than 20 or 10 depending on the day of life, and T4 is more than 10 or FT4 more than 1.17, then we call it as normal. So your confirmatory sample is normal. It was a false alarm. You can just counsel the parents and send them, say bye-bye. So, but if it is abnormal, okay, so let us see the scenarios. So if you have only T4 or FT4 is abnormal, that means TSH is normal, but total T4 or FT4 alone is abnormal. That is, if If it is less than 8 or less than 1.1, then it is an indication for treatment. So you have to start treatment for the baby. Okay. So basing on T4, only T4 if it is low, that is, it is not less than 8 is a cutoff. If it is FT4, it is 1.1 is a cutoff. Then you start the treatment. TSH is normal. If both are abnormal, naturally you start. So what do you mean by both abnormal? Again, I am repeating for you to remember. TSH more than 20 in for a baby who is less than 2 weeks, more than 10 for a baby who is more than 2 weeks. So if this is the scenario and your T4 less than 10, see there is a difference. Total T4, you take a slightly lower cutoff, that is less than 8 if TSH is normal for starting treatment. But if TSH is also abnormal and T4 is 10, so there is a slight difference. Okay. So similarly for FT4 levels, there is a very slight difference. It is a third digit. So remember this. Okay. So if you find this is the scenario, then you begin treatment. So these are the indications to start treatment. Both are abnormal or this is abnormal. Okay, so here you have to treat, no problem. You start the baby on levothyroxine. How much to start? I'll come. Next, suppose now the other scenario, third scenario is TSH alone is abnormal. FT4 is normal or T4 is normal. Then what do we do? Now this is a tricky scenario. What do we do? So you have to repeat. So you can wait because T4 or FT4 is normal. There is no urgency. It could be a just some delayed maturation. Okay, so that is why you are not bothered. Because as long as T4 is normal, we presume that T3 is also normal. So babies, it's not going to harm the baby. So that it is safe for you to wait. Okay, so that is the logic behind this. So if TSH alone is abnormal, then you repeat after 2 weeks. So if the repeat is more than 10, because now he is already more than 2 weeks, if the repeat value also comes as more than 10, then you start treatment. So these are the indications for treating a baby with congenital hypothyroidism. So how many indications are there? 3 indications. The first indication is both are abnormal. Very simple. T4 alone is abnormal. Okay. Or persistently high TSH even after repeat testing. Okay. Then you start treatment. So this is the indication to treat. So these are the 3 scenarios for treatment. Okay. So all these things are from the Indian Society of Pediatric Endocrinology guidelines. So you can go through. It is published in IJP. So please go through that. So read that thoroughly. There are 2 articles published. So one is for how to screen and how to treat. The next one is how to diagnose. Very simple, 3-4 page articles. So please go through them. Okay. So this is the same thing which I told you. So low T4 alone, irrespective of TSH. So low T4 and TSH abnormal or persistently elevated TSH. So these are the 3 indications to start treatment. Now there are special situations. This is for a otherwise healthy baby who just couldn't stay in your NICU. He came and then went. For a baby who is sick enough or a preterm, the situation is slightly different because so many parameters can influence your hypothalamo-pituitary thyroid axis. The HPT axis is very, very sensitive to the sickness. So if a baby is sick or if he is not getting enough nutrition, there could be a problem. Okay. So you can have a TBG deficiency because of the poor nutrition itself, or maybe having a congenital TBG deficiencies. Sickness also impairs TBG deficiency. If you are using a lot of povidone iodine, okay, iodide containing antiseptics for cleaning, especially in preterms, there is a lot of transcutaneous absorption of iodine. So be very careful when you are applying iodide based antiseptics for cleansing the skin for various procedures. Okay. So nowadays, that's why people are moving towards chlorhexidine based skin antisepsis rather than using those iodide based antiseptics. Okay. So if you are still using it, ensure that you wipe out the excess povidone iodine containing compounds. Okay, because there is a significant absorption and that can impair your thyroid hormone synthesis. Okay. Similarly, drugs like dopamine can suppress TSH. Illnesses like RDS can suppress the TSH. So you can have very falsely low TSH, especially the babies on inotropes, babies having significant respiratory distress, or the immaturity of the HPT axis itself because of the gestation, low gestation. So all these things can interfere with HPT axis, and you will get very wide range of values, and you don't know how to interpret. Okay. So in these scenarios, it becomes very difficult to interpret those problems. Okay. So what are the disorders which we see in those sick or preterm units? One is called as sick euthyroid syndrome. So because of all these entities, the babies can suffer what is called as sick euthyroid syndrome. It is euthyroid. The name itself is there. Baby thyroid status is low. Okay. Whether you understand the pathophysiology or not, so don't worry. The importance is the name itself says sick euthyroid syndrome. So euthyroid, why do you want to treat? Don't treat. Okay. The simple pathogenesis is, suppose when there is a sickness, what is happening? The BMR will get elevated, isn't it? So baby's BMR will get elevated. So when a baby's BMR is elevated, thyroid hormone goes into sleep. That means the thyroid, the active form of thyroid, that is T3, is going to be lesser. So more T3 will get converted to reverse T3. So T3 will go into reverse T3. Okay. So T3 will become RT3 to reduce the active form of thyroid. So you will find an elevated RT3, okay, and T3 will be low. T4 initial phases will be normal, but as the sickness continues, then T4 can become low, okay. TSH will remain normal, okay. So this will happen in the initial phases, okay. So as the baby goes, as the sickness goes, so what happens is T4 can become very low. TSH surge will not happen because there is hyporesponsiveness of the pituitary to the low T4. But during the recovery phase, what happens? This is the phase one. Okay, in the recovery phase, what happens is, as the baby is recovering, T4 is low. Now the pituitary responsiveness will start, so TSH will increase. So this phase can mimic a hypothyroidism. So you may have a low T4, you may have a rising TSH. So when you are doing thyroid screen during the recovery phase of a severe illness, so it may mimic a hypothyroid state. Okay, so that you should be careful. So when a baby who is recovering, if you get these kind of borderline values, but these, remember, these will be borderline. It will not be like TSH will be say 40 or something. Okay, so if you find a TSH of 40 and T4 of say 2 or 3, that means that baby definitely has a congenital hypothyroidism. But these numbers will be borderline. So when these numbers are borderline and a baby you feel is recovering from the illness, then probably you may repeat the screen and then before you jump and start treatment. So that you should remember. Okay. So the other disorder which you see in preterms is the hypothyroxanemia of prematurity. Name itself says it is hypothyroxanemia, that is T4 is low. TSH will be normal. Okay. Same story. Because T4 is low, there is a hyporesponsiveness of the pituitary because of the immaturity of the HPT axis. TSH surge will not happen. Okay. So in such a scenario, again, you don't treat. In both these scenarios, no treatment because they are transient and the babies tend to recover by themselves. Okay. The only thing you have to do is treat the illness and manage the prematurity. That's all. So don't think about treating the thyroid because there are a lot of studies where people have treated this hypothyroxemia of prematurity and they found that outcomes are not any good. And in fact, there are some studies which show that it may cause harm also if you treat a hypothyroxemia of prematurity. Okay. So that is why never treat a hypothyroxemia of prematurity, never treat a sick euthyroid syndrome. Yeah, I'm sorry. Yes, so you will have a low T4 and then normal TSH as I said. Okay. So in a preterm, how many screens you have to do? So because of this illness phase, so most of the guidelines recommend at least two screens. Okay. So two screens are required for treating a preterm baby. Okay. The first screen is you may do it in the as early screen, just like you do it for any other baby, day 3 or day 4. But if the baby is too ill, then you may skip that, but at least do it in the first week. So by the end of the first week, first screen has to be done. Whatever the gestation, whatever the illness, so you are supposed to do in the first week. So if the first week is say some borderline values, don't worry. But if it is too abnormal, then probably you may have to follow the same guideline as you do for a term healthy baby. Uh, but because of illnesses, inotropic support, immaturity, all those things which I said earlier, so babies do need a second screen for confirmation. So you have to do a second screen at 2 weeks of life if the baby is getting discharged early. That is, he's a moderate preterm, so didn't have much issues. You are discharging the baby. But if it is very small baby required long stay, then you do it at 4 weeks of life. So at least two screens are recommended. If you look at the Western guidelines, either a European or American guidelines, they recommend three screens for preterms. The first one here, second one at 2 weeks of life, and the third one at 4 weeks or at discharge. So they recommend three screens for a preterm as far as Western guidelines are concerned. But Indian scenario, because we are lagging with universal screen itself, they don't want to overburden the system. So they are taking the middle path. So they are recommending two screens. Okay. So this is what is indicated. So two screens are required for a preterm. So don't differentiate a term or a preterm. Practically do a screen in the first week of life and remember to do another screen if the baby is getting discharged at 2 weeks or at least at 4 weeks. Okay. So you can just send a TSH. No need to do a T4 and other stuff. Just send a TSH for both the screens. But if it is abnormal, then you do the confirmatory screening as you do for a term healthy neonate. So as I said, no treatment for acute thyroid or for the hypothyroxemia of prematurity. So it is recommended only if it's a case of true CH. Okay. So diagnosing a true CH in a preterm is quite difficult because there are gestation-based cutoffs for E4 and TSH. So you have to follow those numbers and then do the consider treatment in case of a preterm baby. So you have to look at the tables are available. So please look at even the SPA guidelines has given a table at a different time point, different gestations and different postnatal ages. So please go through those and then decide whether that baby fits into a true CH or not. Now, you have done all these things wonderfully and you have decided to treat. So when you are treating, the dose is 10 to 15 microgram per kg per day. Higher the dose is required, I used begin at a higher dose, especially for babies who are having a very high TSH. So as I said, the baby's TSH is touching 60, 70, 80. In those babies, it is always good to begin at a higher dosage because we want the TSH, we want the T4 to normalize as early as possible. The goal is to normalize the TSH, not TSH, T4. Normalize the T4 within 2 weeks of starting treatment. This is very important. Please remember, our aim is to get the T4 normal within the first 2 weeks after starting treatment. Okay. So TSH will take time to come to normal. So don't worry about that. The important thing is a normal T4 after 2 weeks of treatment means you have done a good job. So our aim is this, the biochemical aim is to keep the TSH in the low normal range and T4 in the high normal range. So this is our aim. So that much dosage you are supposed to give. Okay. So how do I know whether they are getting normalized or not? Should I do immediately or within 3 days after starting thyroxine? No. So you have to give at least 2 weeks for the T4 to normalize. So after 2 weeks of starting this, so you have to call them back and then do a TSH. If financial constraints are there, TSH is enough in the follow-up. But if they are okay, then better is always to do both. But if there are financial concerns, you can get away with TSH alone. Okay, so that is our aim. So it has to be done 2 weeks after starting treatment. Now, on the follow-up, what should we do? So it is not just the biochemistry. Always look at the baby also, whether he is growing normally. So it is not just the weight. Anthropometry doesn't mean weight. Here it is for every baby, it is important. It is all the more important that you look at the brain growth and the linear growth. So length and head circumference are very important. The baby is not growing linearly. That means your thyroid status is not adequate. If the head circumference is not growing appropriately, that means you are not managing the baby properly. And of course, developmental assessment is very, very important for all neonates. And here it is all the more important. So assess all the milestones properly and to check whether you're doing the right job or not. So initially, you may have to do it very repeatedly, at least once in 2 weeks you have to do till at least 1 month or 2 months of age. After that, you may do it every monthly for 6 months or once in 2 months for 6 months. And then you can be little lenient every 3 months till 3 years of age. So 3 years of age is the mandate minimum requirement of follow-up for any baby for whom you are beginning a treatment. So counsel the parents adequately that it is not 1 month or 2 month treatment. Once you start thyroxine means you are not going to stop it. In most of the 99% of the cases, you will not be stopping it till 3 years of age. It is extremely unlikely that you will taper and stop before 3 years of age. Okay. So proper counseling is very, very important. Otherwise, compliance becomes a bigger issue. Okay. Now, what practical tips you will be giving to the parents? So you should be giving the drug, ask them to keep a particular time. Okay, so ensure that preferably in the morning at some time at 10 o'clock in the morning, for example, every day at the same time, the mother or father has to give the tablet to the baby. So sticking to the time is very important. So ensure that you give that guideline to the parents. So ask the mother to express few ml of a spoonful of breast milk, 5 to 10 ml. Ask her to soak the thyroid tablet in that milk. Once it gets soaked, crush it and then feed that milk to the baby. It is better to avoid putting the tablet in the full cup of 30-40 milk because baby may not take 30-40 milk and it may spill. So you may end up causing underdosing. So this is very important, especially for babies who are on say gavach feeding, for example, spoon feeds. So ensure that they don't put it in 25 or 30 ml milk. So they should put it in a very few ml of milk so that the entire dose goes into the baby. If the baby vomits within half an hour or so, ensure that ask them to repeat the dose. And another important thing is, suppose the mother has given that, she should not be giving the other supplements immediately. No calcium, no iron, no vitamin D, nothing. Don't give any other drug along with the thyroid because most of them will interfere with thyroid absorption. So at least for 2 to 3 hours, not to give any other drug to the baby after giving thyroid. And the more important thing is regular follow-up. So baby needs to be followed up regularly. Okay. So that is, and proper follow-up is very, very important to ensure an optimal dosage is given to the baby. Okay. So these things are, you should ensure this. Now, finally, coming to diagnosis of etiology. So as you have seen, I haven't touched about etiology till now. I've even told you about treatment also, because that is most important. Diagnosing the etiology of congenital hypothyroidism is secondary. There is no urgency at all. Whatever be the etiology, treatment is going to be L-thyroxine only. So you have to treat the baby first. So that is the importance. Okay. So don't wait for the diagnosis of etiology of congenital hypothyroidism. Don't wait for that. You can do it on a leisure space. Leisurely you can do it. So don't worry about that. Now, if you want to diagnose the etiology, two tests are really mandatory. One is ultrasound The next is scintigraphy. These two are important. Some babies may need, you have to do thyroid TSH receptor antibodies. You may have to do a TBT levels also. Now, briefly, ultrasound of the thyroid will tell you, clinical examination also will tell you whether there is a goiter or not. So, you have goitrous hypothyroidism, non-goitrous hypothyroidism. That itself will narrow down the etiology to some extent. So, if there is no goiter, you get an ultrasound done to look at whether the gland is really present or not. So, absent gland, small gland, enlarged gland, or a normal sized gland. These are the different things you will come across in the report. Okay. So, basing on that, if the gland is absent, so that means it is aplasia of thyroid. But it can be ectopia also, isn't it? So, picking up ectopy is very difficult by ultrasound because lingual thyroid is very difficult to pick up by ultrasound. So, that is why scintigraphy is also needed. Okay. So, ultrasound of thyroid alone is not enough. So, you have to do both. So, ultrasound as well as thyroid nuclear scan both have to be done. Then only you will be arriving at a proper etiology. So, just because you have started the treat babies on L-thyroxine, that it will not going to interfere with your thyroid scintigraphy. So, you still have at least 1 week window for doing a scintigraphy. Okay. So you can still do it, but if the baby is already on a say a 2 to 3 weeks of thyroxine, then scintigraphy can change. Okay, so better to avoid. There is no, as I said earlier, there is no urgency at all to find out the cause. Okay, so ultrasound is very simple. You can do it on all babies. Then scintigraphy is also required to get at a proper etiology. Okay. Uh, Absent gland, it could be this or it could be ectopic. So ectopic can be picked up by thyroid scan. So thyroid scan will show the gamma camera will pick up tracer from the lingual base. So then you know that there is an ectopic thyroid. So the presence of ectopic thyroid tells you that baby dosage may not be very much. You will be able to come down on dosage, but still the baby will need treatment because the ectopic thyroid gland is not big enough to support the growth of the baby. Okay, so don't jump and stop the treatment. So as I said, once you start the treatment, it has to be for at least 3 years. And these ectopic thyroid babies, they need treatment for lifelong because the gland is not enough to support the growth of the baby. Okay, so you need additional dosage, but the dosage will be lesser. If it's a hypoplasia, then you will know the gland, the uptake is also reduced. Then thyroid hypoplasia, you can diagnose. Okay. Now, if the ultrasound is showing an enlarged gland, that is goitrous hypothyroidism, the scintigraphy can show an increased uptake, it can show a reduced uptake, or it can show a normal uptake. So all are possible. The gland can vividly take up the dye, that is the nuclear dye I-131. I-123 is not available in our country, so it is I-131 is what is used. So it may vividly take it up. So if it is vividly taking up, possibly you are dealing with a iodine deficiency, endemic iodine deficiency. If it is not taking up at all, then the gland is getting suppressed because of probably antithyroid drugs. So if the mother is on, say, mother is hyperthyroid and she is on, say, methimazole or carbimazole or propylthiouracil, there is a transplacental transfer, especially if mother takes methimazole or carbimazole, there is a significant transplacental transfer and that can lead to suppression of the baby's thyroid. But luckily that will be a transient entity. Okay. So clinically also you will know as a baby grows up, your thyroid requirement dramatically comes down because the native thyroid now starts functioning in the baby. Okay. So rarely in this scenario, you may stop the treatment if even the lowest dosage of thyroid, if it is causing TSH suppression, then you may take off. But that is the rarest, I mean, that is not very common scenario. Okay. Uh, Suppose if there is a reduced uptake in all glands, thyroid, salivary, and gastric mucosa also, then probably you are dealing with a specific gene mutation, which is called as NIS gene mutation. If it's a normal uptake, gland goiter is there, but uptake is normal, then you have to do something called as perchlorate discharge test to diagnose dyshormonogenesis. Probably you are dealing with a Thyroperoxidase enzyme in a problem, then dysharmogenesis is a possibility. If it's a non-goitrous hypothyroidism, gland is there, normal size, that is no goiter, but then again you will have same possibilities. It could be a rapid uptake, it could be no uptake or a reduced uptake, or it could be a normal uptake. So all are possible. So if it's an increased uptake, then endemic iodine deficiency. So iodine deficiency can manifest as a goitrous hypothyroidism or a non-goitrous hypothyroidism with increased uptake. The clue is increased uptake in the thyroid nuclear scan. If there is no uptake, again NIS gene, if there's no uptake in all the glands like thyroid, salivary and gastric. If it is a no uptake and the gland is normal, then probably you are dealing with a thyroid binding inhibitory immunoglobulin, that is receptor antibodies. So TSH receptor antibody related to this. Okay, so you can measure those antibodies, and if you find that, then counseling becomes difficult. Then you can say that it is not going to be a lifelong problem. It is a transient entity which is going to settle for a period of 6 months. So if it is a reduced uptake, then the other cause are possible. Excess iodine exposure, that is also possible. If it's a normal uptake, peripheral CH is possible. Okay. So in this way, you will able to narrow down the etiology. So don't worry about all this. Okay, it's simple if you can understand the concept. But even if you don't remember, don't worry. Simply refer to a endocrinologist. They will take care. But your job is to start treatment. Don't wait for the pediatric endocrine opinion for starting treatment, okay? Because starting treatment is kind of a semi-emergency because you want to normalize the T4 levels as early as possible. So please start the treatment once you confirm the congenital hypothyroidism basing on the lab values. Okay, so that's it. So I'm not going into hyperthyroidism and other stuff. This is because screening for a thyroid was a talk, and I think time is also a limit. It's already 10:30. Most of you must be sleepy.
Thank you, Sriram sir. I think it's been a kind of very long session today. I thank all the faculty for taking out their time. There are a couple of very quick questions. Akshay Hola has asked if TSH is more than 80 and free T4 or total T4 is normal. Do we retest TSH after 2 weeks or do we start treatment?
That's a very unusual scenario.
Yeah,
If you have a TSH of so much, your T4 is should be low.
should.
So in such a scenario, you just, if it is really a clinical possibility, I think that is more of theoretical possibility what you have shown. So if it's such a
Yeah.
case, then you can wait, no problem. As long as I said, if T4 or free T4 is normal, there is no urgency because baby thyroid status will take care. But if T4 is also low, then it becomes a real emergency to begin the treatment.
Another question, should we continue treatment even if normal TSH values come up at follow up for 3 years?
Yes, you have to because your medication has normalized the TSH. So at 3 years of life, at 3 years of life, then you can stop gradually taper and stop for a period of 4 to 6 weeks, and then you restart. So you stop the medication for a month, and then you retest the TSH and T4 values. Then you can decide if if there is a TSH surge, then definitely you have to restart. Then it becomes a permanent entity. So that is why you can take a call at 3 years, whether it is a permanent entity or transient entity.
Is there any reason why we choose 3 years? Is another question. Why 3 years
Yeah,
for the
3 years
trial of?
is basically because hopefully most of the brain growth is done by that stage. So it is safer. Previously it was 2 years, but now they have made it 3 years. Maybe after some time it may become 5 years also. But now it is 3 years, because most of the brain growth is okay, and we are okay for stopping thyroid for a month at 3 years because brain growth is almost over.
So do we start higher dose of thyroxine for thyroid agenesis?
Yes, they will need a higher dose. As I said, if TSH is really high, say something like 100 or something, you begin at 15 mics per kg. So you begin at a higher dose only because your aim is to normalize the values as early as possible. Normalize T4, not TSH. TSH in any way will take time.
On treatment, if TSH is becoming low, then should we still continue treatment?
Yeah, if it is going, as I said, you have to keep it within the low range of normal. But if it is becoming really lower than the normal range, then you have to adjust the dose.
Dose.
So probably, but
Okay.
not stop it. Don't stop it. You have to adjust the dose and then repeat it after a month.
Yeah. How do we counsel parents about the long-term follow-up?
So you have to talk to them. That's the only thing you can do. So because this is a treatable disease, so you have to ensure that they understand the importance of giving the drug daily. Because if they give it properly, the baby is going to do just as any other normal child. His IQ is going to be normal. He's going to develop up normally. The height, weight, everything is going to be normal. So all the positive aspects you have to emphasize to them and ensure that the compliance is there. That is the most important thing you have to take care.
Yeah. I think we have answered all the questions. Can we reduce dosage if TSH is getting low? I think that has also been addressed in the discussion. So thank you very much, Sriram sir, for your extensive and elaborate discussion and for patiently answering all the queries. Okay, there's one more question which just popped in. Clinical signs during treatment.
I didn't get it. Clinical signs?
I think they are asking for clinical signs that are to be monitored during treatment, like signs of
Yeah, so
hyperthyroidism.
probably you have to look for. So one is, as I said, linear growth is one thing. Okay, so the baby is not growing. If you overdo or underdo, the growth can falter. Keep a check on heart rate. Sleeping heart rate is another very sensitive marker. If the baby is sleeping and the baseline tachycardia is there, then probably your dosage is going higher. So anthropometry, vital sign monitoring, so all these things will tell you whether you are doing a good job or not. And of course, lab values will always help you out.
Yeah. Right. Thank you so much, everyone, for joining, and thank you, Sriram sir. And I think it's been a long day. And wish the students do their exams well. All the best, all of you. We have, I think, couple of more feed sessions before I think we wind up, and you all go for your exams. So happy reading, and we'll again meet next Wednesday. Thank you all, and good night.
Yeah. Thank you, Dr. Aparna. Yeah,
Thank
all
you,
the
sir. Bye
best.
bye.
All the best for all the students. Yeah, bye bye. Good night.
Yeah. Bye bye.
Right, ma'am.
Thank you, Sarita ji. Bye.
Bye, ma'am.